Now, after all these fantastic diagnostic techniques, we need to think why we're doing this. If you're going to diagnose that tiny 5 millimeter lesion that Ralph found, and then send the patient for colectomy, then I think half of the objective could be, you could say that it's defeated. Because you could save his colon by using some excellent endoscopic technique. So I'm not saying that we are here to replace, but there are lots of things that we can do and avoid surgery. I'm sorry, guys, my videos didn't work on this, so I'll have to play from my laptop. That's where I work at the Queen Alexandra Hospital. Our center is called Solent Center of Digestive Diseases. But the way my work is going, sometimes that's how I feel. It's a center of difficult diseases. And all of you who have interest in this field, get ready for that, because life is going to get more and more difficult if you have interest in this field. I think the business for endoscopic resection is going to grow. There's a huge, all these advanced diagnostic techniques are finding so many things that we'll have to get smarter and resect. I think we're going to do a lot more of the same because we're finding a lot more polyps, we're finding a lot more early lesions, so we are going to do more. And I think what we're doing is going to get bigger and bigger. People who are taking on 2 centimeter polyps today, I'm sure 2 years later they'll say they're doing 5 centimeter. Those who are doing 5 centimeter could go up to 10 centimeters. So I think that's what we will do. All our natural progression is, as we get better in a learning curve, we'll take on more and more challenging lesions. There are some benign lesions that are coming, which were traditionally always believed to be surgically cured, and I think endoscopic techniques can help with that, so I'll try and talk about those. There are some new cancers and new challenges which we can meet with endoscopic techniques and some new techniques. So very quickly, just to highlight, that's what's happening with adenocarcinoma. So more cancers, we're going to see more. I think we're going to diagnose more, so we have to get better with our techniques. Future is big. So if this is what the direction of travel is, we all know with obesity comes colon cancer, esophageal cancer. This is a slide that I borrowed from Hugh Barr. I don't know how Hugh managed to get this, but it's a fantastic slide which shows that our business is going to get bigger as the population gets bigger in size. So it's good. I think this is all I'm not going to go into because we talked about how we're going to diagnose better and more. All these things that we are currently doing will improve all the early diagnosis. So we're going to do more of all these things that most of us are doing or thinking of starting. Let me get straight to what's happening with gastric cancer. The biggest problem at the moment is we're not diagnosing enough early gastric cancer. So that's the first challenge. I think the big problem there is not technology, it's the lack of knowledge, what they look like. And second is experience and skills. We just do not know how to identify them, and even when we see them, we can't diagnose them. So that's the big challenge we have to face because the incidence of early gastric cancer is lower than what people in China, Korea, and Japan get, so we don't experience enough. So I'm sure we'll get better with that. But at the moment, I think we are treating all our early gastric cancers with EMR. I think this is going to be replaced. EMR technique for stomach is not as safe and good as it is for esophagus because that's a straight organ. Tangential suctioning and tangential resection helps. Here, it's a very mobile organ. The wall is big. As you suck, if you suck too much and the lesion is wrong, like there was scarring on that lesion, I don't know if you noticed. If you have scarring, you do this is what happens. Okay, so this is the wrong technique for a wrong lesion. I think as we get better, our learning curve get better, we will certainly move from EMR to ESD in stomach. I'm very sure that opinion is quite strong, at least for early gastric cancers, that we shouldn't be doing EMR. This should be resected by ESD. You've seen this lesion, looks suspicious, but once you've seen enough of these, you know this is high-grade dysplasia, stroke intramucosal, nothing more than that. The stomach wall is quite thick, so even if your experience is low, you can use ESD here after proper training, of course. And you can see very slowly get into the planes. We've now isolated it from the normal mucosa. Once the whole lesion has been isolated, that's where the challenging bit comes. To do that submucosal dissection, I think that's where we need to invest. That's where you have to work hard. That's where the biggest learning curve is. How to get in there and maintain your plane, that's the trick. The surgeons are very good at knowing the planes and staying in the planes. We are traditionally not trained in that way. That's what we have to train ourselves, is how we get into the right plane and maintain that plane, knowing that muscle is below us. Once we know that, we'll get better with ESD, and I think in stomach, that's what we're going to do. Ampullary lesions, I think we're going to diagnose more of these because we're doing a lot more gastroscopies, a lot more surveillance, so more of these will come along. They look scary, but once you got your basics right, once you know your surface patterns, and you evaluate them well, and you know what is safe, what is not safe, I would say this is probably the most risky technique that we do. Doing ampullectomy probably has the highest risk profile than any other endoscopic resection technique we do. So you have to have a team, you need to know what we're doing. So we resected that, we put a pancreatic stent in already, we're going to do a sphincterotomy and check for any intraductal extension to make sure there's no intraductal extension. So it's knowing the principles of it, having the technique, having the team, everything. I think cholangioscopy is already happening. Some of you have seen those spyglass. I think the spyglass image is so poor that I felt like I'm looking down my frosted glasses, hardly see anything. Here we're putting a guide wire followed by a balloon, and then a transnasal gastroscope is being railroaded onto it. We entered the bile duct, that's a stricture in the bile duct, and you take a biopsy. It's just an imaging view of the same, how the transnasal gastroscope is following the guide wire and the balloon into the bile duct, and you can get excellent views I showed you there, and you can take the right biopsy of the right area. And who knows, in future, once you find that stricture, you might laser it, you might RFA it, you might do all sorts of therapies down there. So they're getting access. So we're getting good at access, and that's what's going to determine some of these cases that we do. I've talked about bigger things. Look at this. It's a big, big carpet adenoma, and very flat, very difficult to lift, very difficult to catch in your snare, but we are doing now is EMR for them. It's about 3/4 of the circumference, quite low in the rectum. Most important step here is evaluation. Spend about 20 minutes washing, cleaning, staining, whatever technology, high magnification, zoom, eye scan, NBI, doesn't matter. Whatever your skills are, whatever your best technology is, use that to make sure that there is no cancer in it. Once you're happy, then it's a very, very systematic approach. Start from one side, move to the other side, don't leave islands. Always use the EMR base as a divot to catch the next bit of the adenoma. Keep progressing. You have to be very smart in bleed control. You'll see a lot of oozing, a lot of bleeding, and unless you have those skills, you will struggle because very soon everything becomes all red, you're washing, everyone gets frustrated. So it's very, very important to get your bleed control skills right. And you can see it's a beautiful EMR base. Unfortunately, specimen won't look that beautiful because I've taken about 20 bites there, so pathologists won't be happy here, but it's been done quickly, safely, and there is no residual adenoma. I think because of that main thing about pathology specimen being so poor, earlier question that you asked about R0 resection rate, the confidence, if there is cancer in it, the confidence of reporting it, the confidence of telling the patient that I've got all your cancer out, don't worry, is very low. And if it is a surgically fit candidate, then your threshold should be very low to offer him surgery because you can't be sure when you chop things into 30, 20, 15, or even 5 pieces that you've got it all right unless the pathology tells you. And most of the time, pathology won't tell you. So this is what we're going to do, is we're going to start moving towards one-piece resection. It'd be great to go from EMR one day to ESD next day. Unfortunately, that's not going to happen. So if you were in Japan, yes, you could be trained. You can work with an expert. They say you do 30 cases with me and you can become independent. And I find it incredible. that in 30 cases people can become independent in ESD. I personally think the West has to approach a separate technique, our own way of learning, and I think that will be a stepwise progression. So we start with hybrid technique. Within the hybrid, we start with various steps in hybrid, and I'll give you a very quick example. First of the hybrid could be using cap and snare technique and a duet in combination. Why do you need to do that? Well, I was very worried that this could be cancer. If it's cancer, then I do not use duet because I do not want to just put a blind band on an invasive looking lesion and blindly excise it, because either I'm going to go cut through the cancer or the cancer will bring the muscle with it. So I like to inject it, lift it, do a cap and snare, then all the flat bit very quickly duet. Why change to duet when you already have cap and snare? Because that's a bit fiddly. It takes time. The snare goes away within 1 or 2 use. That's all you get with it. So open another pack or go to duet, which is quick. So I think it's about time how you can efficiently progress. You can combine two techniques. How are we going to go towards ESD? Well, the first thing is to learn the easy bit of ESD. And the easy bit of ESD is mucosal incision. You learn, this is a very nice knife called hook knife. Surgeons in the audience would be very familiar. They use it in laparoscopy all the time. But the other way around, I think they use the elbow of this knife. We use the hook. You just hook around, cut in the normal mucosa, made enough cut, and then use your standard snare. Now you say, why on earth are we cutting when you're snaring and chopping into pieces? Well, you'll never get to the full ESD from day one. So this is how you're going to start. You haven't done any harm here. You have cut in the mucosa. What you've done with this technique as compared to EMR is that you cut in the normal mucosa and then you resected everything on this side of the cut, means the recurrence rate of this big lesion is going to be very, very low. And you can be very confident about that. So that's how clinically it will help the patient. To you, you'll get better with your learning curve on EMR, on ESD. Now, there's a lot of data coming, all these LSTs, how the risk of cancer is so high. Look at that, 20%. These granular type of LSTs, which we all accept can be removed and should be removed by EMR. When it comes to non-granular LST, it's very scary, 14%. And if the size goes up, very high risk. Can we afford to chop these into pieces? Probably not. We have to adopt a technique which is different from chopping them into pieces. We looked at our EMR data, big polyps between 20 to about 15 centimeter in size, 20 millimeter to 15 centimeter in size. And what we found, although our outcome data was quite good, but the 10% of our specimen had cancer in it. I'm not saying invasive cancer like SM2, I'm saying SM1 type of cancer. Because I chopped it into 3 and 4 pieces, the confidence of that report is very, very low. On surgery, he didn't find much in these patients. But you cannot sit on that report comfortably when a cancer is reported and you had 5 pieces of that specimen, because it's just very uncomfortable, because the accuracy of that SM reporting, the accuracy of clearance of the lesion is very poor. So I think this is what is going to push those high volume EMR centers from EMR to ESD, because we can avoid this. Majority of these patients had SM1. If I'd removed all in one piece, very good report. I tell patient, you got SM1 cancer, no problem, no lymphatic invasion, no vascular invasion, your deep margins are clear, your lateral margins are clear, fine, no need for surgery. But can't do it if you resect it into too many pieces. So the next step towards ESD, how are we going to get there? From those little incision to, when you get better with this, you start doing full circumferential incision. You'll see here, you inject, you lift, and you start cutting now. And you don't cut just little bit at a time, but your aim here is to do a complete circumferential incision with little bit of submucosal dissection. So you don't go underneath the lesion fully, but you do dig a trench in there. So you see that? It's retracting away from the incision margins. So because of the submucosal dissection. So do that little bit of dissection, cut, keep going, and then do a little bit of dissection in that same margin, and then you can use a snare and you can resect it in one piece now. So you moved from that little incision to multi-piece EMR to this full circumferential incision and still using a snare, but getting a very good one-piece resection, much quicker and much safer if your submucosal dissection technique is not very good. this is another lesion, Dallman. If you have Dallman colitis, traditional teaching always says, oh, have colectomy. Well, you don't really need to have colectomy if you can resect these in one pieces. Again, you have to decide what technique you're going to use. If you're going to, you can't do ESD, is it safe to remove by EMR? Possibly, if you can be very confident of margin and you can rely the report. Most of the time, they are low-grade dysplasia, so I don't think there's a big problem with that. But ideally, in colitic bowel, it's very difficult to lift. The best technique is ESD, and that's again where the ESD is going to play a role. And see, you just have to maintain that plane, and once it shrinks down like that, it's retracted. Now this is probably about 3 hours down the line when my back's aching, I've had enough, I'll get a snare out. So there's always a bailout mechanism, and you've got to work on that, otherwise you can't. You could be doing for about 8-10 hours to carry on with the knife. So you get a nice one-piece specimen. Once you get good, your technique gets good, you've done lots of hybrid, lots of mucosal incision, little bit of submucosal dissection, then this is my biggest ESD I've ever done in one piece without bailing out with a snare. But I don't know if you can see the date there, 1st January this year. I've probably done other full ESDs, but never to this size before this. And I started playing with the knife back in 2005. So this has taken a long time. It's a long process. It's a long process of self-teaching. It's a long process of adapting and evolving how I can train myself without the Japanese experts. But then you slowly get there. You slowly learn all the techniques. You slowly understand your planes. You know exactly how to start, how to finish, what is the muscle layer, what is not the muscle layer. All those understanding of planes, nobody can teach us. We have to be in there. We need to see that and understand it. That's the only way we can learn. So once we get good at all those, that's the time when you start allocating 3-4 hour session to this and start doing it. And then that's just the skill side of it. Who's going to support it? Your colleagues should be on your side. Whose surgeons should be on your side? It has to be a service. You can't be just one-off, you can go and learn and do it, because you can do 1, 2, or 3, and then the managers will clamp it down. So you have to look into all those things. So that's why it takes so long. You have to address all those things. They just can't get a skill and start doing it. You'll have to develop all those things at the same time, but then you get this lovely specimen. Now this is where you can talk about R0 resection. This is where you can talk about SM invasion and the depth of invasion and how deep and all those things, and be very, very confident now and tell the patient, I've cured you, don't worry, we'll have a look in 3 months' time. I'll go very quickly because I'm sensitive about the time. That's another carcinoid high up there. It was very difficult to find. After they found it, they couldn't find it again. They would send him for US. The US guy said, there's nothing, everything's wrong with this, nothing wrong with this stomach. They are submucosal lesions. Be very, very careful when you're dealing with carcinoid. They start in submucosa, they can go deep. Use a standard suction EMR ligation technique, you'll find yourself into big trouble. And I already know about 2 or 3 centers who have found themselves in big, big trouble resecting carcinoids by standard EMR technique. That's where, again, ESD is going to play a role. You have to get into the plane. You have to know that hasn't gone to the muscle, because EUS is not sensitive enough, CT is not sensitive enough, and if it is sitting right on top of the muscle, you will suck the muscle through. So that's, again, getting into the planes, dissecting, taking it out. It is a cancer, and we have to respect and not chop it into pieces, because if it comes at one of those high-risk ones, then you will be in trouble. So again, that's where we'll play a role. That's another GIST, suspected GIST here. Was going to have a distal gastrectomy, although this EUS doesn't show it originating from muscle. Looks like clear, but I can't be sure. So let's just operate. And the biopsy is not confirming it, but it definitely looks like a GIST. We've done a joint approach. I wasn't sure. I don't do GIST routinely. So we asked the surgeon to put a laparoscope in. I've switched my lights off. He switched his lights on. He looked at it from outside and said, it looks absolutely fine. There is no extension through the muscle here. I moved it around. I was happy. I injected. I could see the lift. Once we did all that, it's just because we're not sure about the US finding, that they can confidently tell me that this is not originating from the muscle. And that's when ESD helps. In the sake of time, I'll cut through this, but just staying in the plane, the advantage here was the weight of it dragged it away, so opened up the planes for me. It was fantastic. I thought God was helping me that day. Just pulled it away by the gravity, and we could stay in the plane and take it off. These are the other things we could do. A leiomyoma in the esophagus. This is a patient from London who came down to us because he read about it and he said, I'm not having esophagectomy. I'm only 45-year-old. I'm not going to sacrifice. I'm going to look at other options. It's a very dangerous game here. You see the bubbles here? This is what's going to happen. You need to have experience of dealing with this. What are you going to do? Nobody has ever seen me doing ESD as fast as I did after I saw those bubbles. There are two options. You put a clip, you panic, you call the surgeon, game over. Nothing wrong with that. You could. I'd been in this situation when I was in Japan. I saw what they could do. Patient was very comfortable. He was intubated. I knew I was in control, and the planes were very good. I knew I was in the right plane. I will get there. So within next 12 to 15 minutes, I finished this, and then I put a clip. The patient stayed in hospital for about 48 hours, had a temperature first night. The temperature came down, stayed on IV fluids, IV antibiotics for 48 hours, and we started with free fluids after 48 hours. And he went home in 5 days. And you avoided esophagectomy and all the complications related to it. But these things will happen, and you have to be aware. Whether you call it complication, you call it part of the procedure, it will be a huge complication if you can't manage it. If you can recognize and you can manage it, then it's not a big deal. But it has to be done as a proper service with the proper backup, everything ready. I will move through these quickly because I know we all want to go. But one thing that will help you guys is we've got to look after ourselves. I do 5-hour, 6-hour long procedures. My back hurts, my wrists ache, and you have to adapt. So I've got this tool ordered where I can sit down and do the procedures. And this is how, you go and see the surgeons, how they work in theaters. They have got all these fancy tools. They can sit down and do a 4-hour-long procedure. Why can't we do it? So you just have to learn from others, put them in our practice, and see how we go forward. This is another very interesting piece of kit that's coming from Pentax. They got a knife and snare. So that's the tip of the snare, which acts like a knife. Once you've done your little incision that I showed you, then you just open the snare and resect it. So that makes it a lot cheaper. Suddenly, your whole cost-effectiveness argument can be beaten here, that this is the snare. I'm going to snare it anyway. I'm going to do piecemeal EMR. So why not I use the knife and snare technique? Use the tip of the knife to do the incision, little bit of dissection, then snare it. See, the tip acts as a beautiful knife. You can do mucosal incision. You can do submucosal dissection. There, we just carry on with your mucosal incision. It's the same snare. We're just using the tip, which is designed like a knife. And once you've done enough of that incision that I showed you with that hook knife, you do the same with this, catch it with the snare, and resect. So once Pentax launches this, I think this will be a great way forward for the ESD enthusiast. Finally, I think there's a place for endoscopic and laparoscopic combination. This is a technique which my colleagues in Japan has developed. They've done quite a few cases now. I'm looking for the right case to do, but haven't been brave enough to get there yet and haven't found the right case either, because most of the time laparoscopic surgeons can do it. But this is something which will have a role in difficult submucosal tumors at the cardia, at whatever the difficult situation is where a surgeon can't just do a local excision easily. So this helps us do local excision of the submucosal tumor without doing a full surgery. So what you do here, you mark it, you do a mucosal incision with whatever knife. Then you use IT knife in this setting because that's what their proficiency is in. And you then do this full mucosal incision, but you don't go all the way around. You do 3/4 of the circumference mucosal incision and little bit of dissection. So you just done that mucosal incision that I was talking on earlier, 3/4, keep that little pedicle on. Then the surgeon puts the laparoscope in from the other side. The surgeon is ready there. At that point, you now perforate the muscle. You use your knife, perforate the muscle, and it's very easy. It would be great to just cut through that muscle. You use your ESD knife now to cut through the muscle. The surgeon sitting right there. You push the lesion out. they put their brilliant kit. Look at the kits they have, these ligashers and these stapling devices. Surgeons got fantastic, their life is so easy as compared to us, fiddling around with these little tools. They put this big gun at the base of it, so you push it out, they put the gun at the base, they cut and they staple, so they cut and they suture at the same time. How fantastic is that? So that's how this technique works. I think they've done about 35 cases now with very good outcome. You can see how beautifully they close and cut at the same time. So I'm sure there will be a role for this technique in select cases, not in all cases, but there'll be right situations, right setting for this. So to conclude, I think this will be the new future. Who wants to take this on? They're not going to be standard gastroenterologists. They're not going to be standard surgeons. They're going to be consultant endoscopists. It doesn't matter which discipline they come from. They could be surgeons. They could be gastroenterologists. We will do a lot more. We will go towards ESD, and I think a lot of hybrid before we reach this full thickness excision. But we got to prepare ourselves and get ready for that. So thank you, guys. But that's the most important slide. You need to build your team. Without team, none of these techniques are going to work. Thank you.